Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to What I Tell My Patients. As today we talk about the management of HER2-positive cancers across the spectrum of different tumor types. This is going to be a very different meeting than the others we're doing this week. We're really excited about it. We have a multidisciplinary faculty tonight with representatives from GI oncology, pulmonary oncology, and breast cancer oncology. And we're really excited to have this opportunity to discuss this with you tonight. This is an important development in the field of oncology that's very important to be aware of. As those of you who have been attending our other meetings here know, this is really to provide a research update to you, to help you be able to help your patients understand, particularly some of the new therapies and new strategies being used in oncology. So we're going to focus on that tonight. But also the issue of patient education and the biopsychosocial model of medicine and oncology, and the question of why was it different to take care of this patient than another patient in the same oncology situation, but a different person. And we'll ask the nurse practitioners on the panel tonight to present cases and get into the human side of oncology, as well as really the human impact on us and on families of this disease and its treatment. And we always like to add in, thank you for the job you do. Your work is very highly valued and appreciated by patients and their families. We're going to start out by introducing our faculty. We actually have the lung cancer people down there on the end, and then in the middle we have the GI people, and then over here the breast cancer people. We like to just create a little bit of a friendly atmosphere, so we're going to start out by introducing the faculty and have them briefly tell you what they do to get away from oncology and the stresses of the field, what they do to have fun. So Lyudmila, you are a lung cancer specialist at the UC San Diego Moores Cancer Center. What do you do to have fun?
I'm a die-hard figure skating fan, so I know who competes for which country, who changed coaches. I watch all their competitions. I know who is the best in each country. And the thing is, I don't know how to skate myself.
Interesting. So Kelly Goodwin, you've been coming to these meetings and working with us for many years. You're at Mass General and the thoracic oncology. What do you do? I know you've had a bunch of kids over the years, but we've been working with you these last 15 years. What do you do for fun?
So I have a 4-year-old and a 7-year-old boy who have unfortunately outgrown cartoons, and it is 100% sports 100% of the time at home. So I'm a baseball mom, a soccer mom, a flag football mom, a track mom, a basketball mom, and they have recently gotten into Premier League soccer, and I didn't realize you could watch Simulation League football on TV, which is people playing the Madden video game against each other on TV.
Interesting.
So I've drawn the line at that one.
So Zev, you're a GI specialist at UCLA. What do you do for fun?
So nice to be here and nice to see you. I mean, one thing that I'm recently into is national parks, and I have a mission with my family to go to all the national parks in the continental United States. So we're about halfway through.
Wow.
So the problem is they're getting older and are no longer interested in these kind of vacations, but that was my dream.
You know, I was just flashing on the fact that last year's ONS, I think, was at Anaheim, and it's always, ONS is right after Coachella. And I view this really as Coachella, and these are the musicians that are playing the next 5 days, and really a privilege to hear what they have to say. So Caroline, you're also up there at the Mass General, one of the great hospitals in the world, and you focus on GI cancers. What do you do to get away from things?
Well, I'm like an older version of Kelly. My kids are 16 and 13, 2 boys, so a lot of sports in my house. To get away from they want me to get away from them while they do their thing. Thankfully, we live in a city where we have an embarrassment of riches with the Celtics and the Bruins, so we watch a lot of sports in my house. I like to cook, and I like to cycle. So that's what I do to get away.
Virginia, you're here in San Antonio. It's really a pleasure to be here. You run the San Antonio Breast Clinic. We've been coming here for forever to San Antonio every December, as all oncologists do. What do you do to get away from things?
First of all, I do want to note that you have the breast people closer to you.
Right.
So appreciate that. It is an honor to interact with other subspecialties that we always try to stay away from. So this is a treat for us. I play tennis, and I try to really take all of my anger for the day and just take it out on the tennis court.
Yeah, I was saying, I'm starting to get into pickleball. That's the other, a little bit faster, but interesting.
So we have this place here called Chicken and Pickle.
Oh, yeah?
And it's extremely popular.
I bet. So, Alexis, you're also here in town. What do you do for fun?
Well, this is my boss and my attending, so I'm glad she gets her anger out on the tennis court and not in the office. Thank you for sharing that. So what I like to do for fun is I like to go to Orange Theory and run, and I like to travel and go on medical missions in underserved countries.
Awesome. So we're going to explore the role of anti-HER therapy in these three different tumor types, and particularly the issue of antibody-drug conjugates, and specifically one antibody-drug conjugate that we've already talked quite a bit about, Trastuzumab Deruxtecan. Before we start looking, it's going to be really interesting to see, this really started out with breast cancer and then got picked up by the other two specialties that we're talking here tonight. But Lyudmila, when you really think about it, we're seeing antibody-drug conjugates popping up all over oncology at this point. There are two approved in bladder cancer. This morning we did a program of diffuse large B-cell lymphoma where now there's an antibody-drug conjugate, polatuzumab, being used first line. Hodgkin lymphoma, brentuximab vedotin now used first line. And we're going to talk in terms of solid tumors. What's your vision about how an antibody-drug conjugate works, Lyudmila? A lot of people view it as sort of targeted chemotherapy. Is that the way you see it?
I'd say it's a smart chemotherapy. So the way I explain it to the patients, like a Trojan horse, you bring in something that the cancer doesn't think it's chemotherapy, and then it internalizes it, and then the chemotherapy breaks through, allows it to deliver chemotherapy at a lower dose directly to the cancer cell.
And in terms of side effects, Zev, I'm kind of curious, initially I think the thinking was you wouldn't have any chemo side effects, but I think we are seeing that some of the chemotherapy does go systemically, and maybe not as much as IV chemotherapy, but you can see GI effects, even I've heard alopecia. What have you observed with these types of agents, Zev?
Yeah, all of the above. I think that we have to be careful when we explain this to patients and make sure that we explain that this is not a pure antibody. This is not a pure targeted therapy. It has a targeted therapy linked to a cytotoxic chemo, a good old-fashioned chemo, and it does induce these kind of chemotherapy toxicities, whether they're GI toxicities or the more obscure ones, which we'll talk about tonight. But it certainly has a toxicity profile that's more like chemo than like an antibody.
So, Virginia, we've talked about the trend. There's a very strong trend now in oncology to look at biomarkers to assist in managing patients. There are many different biomarkers that we're looking at right now. In lung cancer, you see all types of tumor mutations, and there are targeted therapy for that. But we also have a number of situations where we see biomarkers and it's associated with a therapy that works in that biomarker, and that gets applied across, not outside of a specific tumor type. So, for example, we were talking about MSI high in colon cancer and endometrial cancer yesterday. Can you talk a little bit, for example, about how the MSI story played out across oncology, and also, because that relates to immunotherapy, the issue of high tumor mutation burden as a trigger to immunotherapy?
What we've learned in the past several years is that all of these tumors can have some similarities when it comes to different mutations, different markers, And so, for example, the tumor mutational burden, it was recognized that some tumors tend to have a high burden of mutation, and some tumors tend to have a little bit of a lower burden of mutation. But it seems that immunotherapy works in the tumors that have a high mutational burden, regardless of whether this is a colon cancer or a lung cancer or a breast cancer. For breast, it's a small number of patients, but that's what typically happens. And so we've been using immunotherapy now for both MSI high tumors, regardless of what the tumor is, as well as high tumor mutational burden.
And Lyudmila, another example where you're looking at a biomarker and then apply it across different tumors of the treatment is so-called BRAF positive disease. Of course, we saw BRAF therapy first come out with melanoma, but then we started to see in other cancers, and now there's a pan-tumor approval of BRAF therapy, dabrafenib, trametinib, for example, used in lung cancer. Any comments about that strategy, anti-BRAF, across tumor lines, Lyudmila, and particularly as it relates to lung cancer?
I think the BRAF V600E mutation is one of the mutations where the idea of BRAF targeted therapy works for all of the patients with BRAF V600E mutation is not truly correct. For example, colorectal cancer with BRAF V600E does not do as well as, for example, lung cancer with BRAF V600E. So I think even though there are some similarities, there are some differences, and we're probably going to talk about differences in what does, for example, HER2 means, because HER2 means one thing in lung cancer, means different things in breast cancer.
That's what we're going to get into that. Also, Lyudmila was mentioning colorectal cancer, where you do see BRAF positive disease, very important biomarker. But as she suggested, even though you can use anti-BRAF therapy, you all approach it a little bit differently, add in EGFR antibody, for example. Can you comment on that?
No, I think it's a good point that, while we like this notion of tumor agnostic indications, and that implies that the same patient, regardless of where the cancer started, has the same mutation, the drug should work the same. The reality is, and there are subtleties and nuances within each individual cancer, and colorectal cancer is an example where the concept of a BRAF inhibitor by itself doesn't work very well because of some alternative resistance mechanisms. And so, however, if you combine it with an EGFR inhibitor, like you alluded to, like cetuximab or panitumumab, now the combination can work successfully. So I think within each of these tumor agnostic indications, there are some nuances, certainly.
So now we're going to focus our attention on HER2. And Virginia, can you provide a little bit of an overview? And we like people just describe things rather than use slides. How would you explain it to a patient, for example? What's your vision about what HER2 is and how we measure it?
So HER2 is a protein on the surface of the cancer cells, and it belongs to a group of proteins called the HER proteins, and it's HER1, 2, 3, and 4. And HER1 is actually EGFR. HER3 and 4, we're now developing certain antibodies and antibody-drug conjugates for. Now, HER2 is used, at least in breast cancer, as a growth factor. So once that protein gets activated, then it starts sending signals to the nucleus to make the cell more aggressive and make it metastasize. And so it was recognized back in the 1980s, actually, by a group here in town, that the HER2 oncogene is actually exactly what the name says. It's an oncogene, it's a bad thing. And the tumors that are HER2 positive actually are pretty aggressive tumors. And so subsequently, a group from UCLA was able to show that there is a targeted antibody, Trastuzumab, that can target that protein and really suppress the growth of these cancer cells.
And Zev, I think Virginia's referring to Dr. Dennis Slayman, who kind of is, I visualize him as sort of the father of anti-HER therapy. Prior to that time, actually, when you think about it, the other targeted therapy we talked about last night, endocrine therapy, tamoxifen of breast cancer, specifically targeting the estrogen receptor. Can you talk a little bit about Dr. Slayman's work? I guess it was in the late 80s and early 90s where he brought out Trastuzumab, eventually getting to the point where I guess around 2005, it was proven not only to be valuable to people with metastatic disease, but also in the adjuvant setting. You've been working with Dr. Slayman for quite a while. Can you talk a little bit about sort of how that evolved?
Yeah, I'm happy to, and this recording will surely find its way back to him. But I will say that first of all, Dr. Slayman is one of my mentors, so I can say that I think I consider him a pioneer in vision in oncology in so many respects. But in particular, when it came to something like HER2, this sort of recognition early on with him and a group of collaborators that there's this subgroup of patients behaving differently and a subgroup of patients that is just not the same. And what is it about them? And to chase that down over many years was quite an ordeal. And then to develop a drug together with a number of people to target that alteration is just such a, at the time, seems to us today to be so common, and we see this every week. But back then, nobody was thinking about this kind of thing. It just wasn't in our lexicon of oncology. It was only chemotherapy and maybe some hormonal therapy. So, Dr. Slayman, to have that vision is quite remarkable. And, he continues that, by the way, do lots of things if you follow the breast cancer field. So, yeah, I think we look back now and we say targeted therapy and we take it for granted, but in the 1980s and 90s, there wasn't really this entity of targeted therapy.
So, the idea of HER2 overexpression, Virginia, really started out with breast cancer, and we're going to talk about the fact, and we actually have a case of HER2 mutation, much more common in lung cancer. How do we measure for HER2? What are the different mechanisms? And up until, I guess, about a year ago, what do we consider HER2 positive?
Yeah, absolutely. So HER2 obviously starts as a gene, then it becomes a protein. And so you can measure the protein with immunohistochemistry, and that's the test that we use the most. And so if the immunohistochemistry comes back as 0, it means that there's very little HER2. And very little, by the way, is actually quite a bit, but it's just very little to the pathologist. Then we have a 1+, which means a little bit of staining, and then 2+, and 3+, which is considered HER2 positive. And all of these studies that looked at that were based on how well Trastuzumab works. And so they found out that Trastuzumab works if the tumor is HER2 3+, and in some tumors that are 2+. And now when there's the 2+, we reflex to a test called in situ hybridization that actually looks at the DNA and looks at how many copies of the gene are there. And then there we really have positive or negative in most cases. And so those 2+ cases get reflexed to the in situ hybridization, and then we find out if it's positive or negative, and we know if Trastuzumab works. Now, things have gotten a little bit different with T-DXd, and I know we'll talk about it because we realized that we don't need that much HER2 for T-DXd to work. We just need it to be present. And this is where the story with T-DXd is so different from the story with Trastuzumab.
So, and here's a diagram sort of starting to look at some of the ways that HER2 has been attacked with antibodies and antibody-drug conjugates. Also tyrosine kinase inhibitors, you see there in the middle, tucatinib, lapatinib, neratinib. We'll talk about that. Lyudmila, what about HER2 mutations? We see that particularly in lung cancer. These seem to respond at least to T-DXd. What do we know about these HER2 mutations?
So I think to build on what we were talking about before, so in breast cancer, majority of the usage of HER2 antibodies based on expression of the protein. Lung cancer is very unique because in lung cancer, the HER2 protein can be overexpressed in approximately 60% of the patients, can be amplified in about 6% of the patient, and can be mutated in about 1% of the patients. So talk about needle in a haystack. Very rare mutation. It's a mutation in the tyrosine kinase domain, and it's a mutation in exon 20, and it's called an exon 20 insertion. And what that mutation does, it actually turns on the receptor, making the receptor to signal constantly and giving a signal to the cancer cell to divide. And it's interesting with Trastuzumab Deruxtecan, the efficacy is with the mutation. Response rate is 55%, responses are relatively durable. But if you just take an expression, then response rate is only 25%. So in lung cancer patient, it is important not to just know that your HER2 is abnormal, but you have to know how it is abnormal. Is it overexpressed, amplified, or mutated?
So, Zev, here's a diagram of what antibody-drug conjugates are the key elements of antibody-drug conjugates there on the left. On the right, you see two antibody-drug conjugates we've already talked a little bit about. But can you talk a little bit about what goes into an antibody-drug conjugate?
Yeah, so the technology has really grown dramatically, and you could sort of see that in this slide. One of the key elements that you hear about as a successful antibody-drug conjugate is something called the drug-to-antibody ratio, and the higher the better, presumably, in that you want a active payload, which is not too toxic, to be linked in that what's called the linker, which is exactly what it describes, connects the antibody part of the drug, and that's, let's say in this case, Trastuzumab, to a payload, which is a little dose of chemotherapy. And you want that drug-antibody ratio to be optimized for both insertion, as Lyudmila described, of this Trojan horse into the cancer cell, and then the release of that payload into ideally only those cancer cells that have this receptor, this HER2 receptor. So there are a lot of nuanced differences, and here you could just see the differences between TDM1 and TDXD. And we're going to see a lot more of these in which the technology is becoming increasingly better to optimize that drug-to-antibody ratio component.
In Virginia, at least I thought when I first started to hear about these that they were all going to be the same. And then that got exploded by a trial that compared two antibody-drug conjugates, the two that you see here in the second-line metastatic setting, what had been the standard of care, TDM1, again, an antibody-drug conjugate to HER2, to another anti-HER2, but a much greater benefit, as we'll show later. Any thoughts about what it is, the so-called bystander effect, and whether that accounts for the improvement that you see with one versus the other? And also this issue that now we're starting to see responses of people who are not considered HER2 positive, but sort of HER2 low, how that ties into the way this substance, this molecule is put together.
Yeah, so I think the two ways that TDXD is better than TDM1 is, number one, this drug-to-antibody ratio. And as Zev mentioned, there's the little payload, the drug on the antibody. Well, TDM1 has 3 to 4 molecules of drug per antibody. TDXD has 8. So double the number. Of course, that also makes it a little more toxic, but we'll talk about toxicities later. But the other thing that's unique is the type of linker. And that linker, by the way, was the reason why it took us 20 years to develop these antibody-drug conjugates. It had to be just right. And this is a new kind of linkers called the cleavable linkers, and that means that once the construct goes into the cell, then the linker is able to cleave the drug from the antibody, and that drug goes into the cell, but it also escapes the cell and goes to the nearby cells, and that's the bystander effect. And those nearby cells may not be HER2 positive, but they're cancer cells, and so that drug goes in there and kills those non-HER2 positive cells, and that's why in this HER2 low disease, this antibody-drug conjugate will work.
And that's been so important because, HER2 positive breast cancer is only about 20% of breast cancer, but now you're adding an additional 50% that's HER2 low. So really expanding, at least for this one particular agent. Well, that's sort of some background in terms of the science behind what we're talking about tonight. Let's talk about how this sort of works out in clinical care in these three cancers, starting out with breast cancer. And first, kind of what we've seen with this approach, and then how we figure out sort of where it fits in. So let's talk about some patients. Alexis, you have a 48-year-old woman who presented, I guess, with inflammatory breast cancer. Can you tell us a little bit about her?
So Ms. Hernandez, she's 48 and she's a Hispanic female. She was experiencing pain and some inflammatory changes and presented to the ER on several occasions, and she was given antibiotics for something that they thought was cellulitis. She finally was able to gain insurance after a few months. Here in Bexar County, we provide a government-subsidized insurance, and she was able to obtain that. She had a mammogram that showed suspicious findings, and they did a biopsy, and she ended up being diagnosed with ER negative, PR negative, HER2 positive, invasive ductal carcinoma.
And unfortunately, she was also found to have metastatic disease at that time. I know she got her initial treatment, and currently she actually is on TDXD. Is that right?
That is correct.
Can you talk a little bit about when you started the TDXD, what you said to her and trying to prepare her to receive that, and how it was different to talk to her about it than maybe another patient?
So how I prepared her was we talked about she would have her first infusion over 90 minutes and then subsequent infusions over 30 minutes. I explained to her some of the side effects, myelosuppression, so really talked about neutropenia and those precautions and nausea management. And I really hinted and really enforced interstitial lung disease and pneumonitis. So if she had any cough, fever, dyspnea, or any worsening or new respiratory changes to let us know.
How did you see her as a person that you was receiving patient education? Was she interested to learn about it, or she was just more tell me what to do?
No, she was very interested. She was young, and when she was diagnosed, she feared her life, so she was willing to do everything and welcomed.
Kind of curious, Kelly, when you see patients and evaluate them for the first time, what are some of the things you're looking for and trying to evaluate what it's going to be like to provide information to them to do patient education? What are some of the things you think about when you first meet a patient?
I like to meet patients a week or so before they actually start their therapy so that we can talk while they're still feeling reasonably well. We ask them to bring family members with them. I provide a lot of written information so that they don't have to take so many notes, trying to understand sort of, are they still working? If they are working, how flexible is their employer? What does their employer know about their illness? Have they disclosed their illness to family members? Unfortunately, with the stigma related with lung cancer, many of our patients don't disclose. Even if it's a non-smoking related lung cancer, many of our patients don't disclose their lung cancer diagnosis to people outside, like their very inner circle. So social supports, transportation can be difficult, what their insurance situation is like. And then obviously their comorbid illnesses and what their level of coping is as well. Some people can cope with being fatigued or nauseous when they know what to expect, and some folks are just waiting for the other shoe to drop and are very fatalistic as they're starting to enter active therapy.
So, Caroline, any thoughts about how you sort of evaluate patients when you're first meeting them, particularly in terms of the kind of information? As time goes on, it seems like there are more and more things that we're asking our patients to be aware of. What's your approach? What are some of the things you're looking for when you first encounter a patient? Also, Alexis's patient had an insurance issue. Many patients have that. How does that factor into your initial evaluation?
Yeah, I think it's really important to meet patients where they are. And how you present that information is very individualized. And we try to take the time to definitely see patients before they start their therapy, but sometimes it's more than one visit. Maybe you need a second visit to go over side effects, particularly if they lack social supports, low health literacy, if there's a lot of anxiety. So you definitely have to take into account the patient where they are. It is not a one-size-fits-all discussion. Definitely social supports, do they have family members? Do they live with someone? Do they live alone? How are they getting to clinic? Who do they go home to? What are their other responsibilities? Do they have childcare responsibilities? Are they working? Those kinds of considerations are incredibly important in gauging how to present this information so that they can be armed with what they need to be successful in tolerating their treatment.
So, Virginia, this is a patient, very unusual situation to present with metastatic disease, perhaps related to the fact because of insurance she wasn't able to really get timely care. When you think about people with metastatic HER2-positive breast cancer, what's sort of the sequence of therapies that you're thinking about, and where does the issue of brain metastasis fit in? And we're going to kind of compare across the lines here, but in breast cancer, what about the brain in terms of HER2?
Yeah, and this is probably a typical story of inflammatory breast cancer where people really misdiagnose it, and for a long time, and we see this sometimes with pregnancy or women that have just had babies and they're breastfeeding, and everybody thinks this is an infection, and it can go on for months before it's diagnosed, and unfortunately, this is what happened here. So once we diagnose metastatic HER2-positive breast cancer, the first-line therapy is pretty well established, and it's the taxane, trastuzumab, and pertuzumab therapy, which you see here. And this really has shown overall survival advantage and progression-free survival advantage. And so this is an established first-line therapy. In that second-line setting, now I think we've all decided, based on data, that TDXD is probably our preferred therapy. But this might change a little bit if a patient has brain metastases. And patients with HER2-positive breast cancer, around 50% of the metastatic patients will have brain metastases. And the most likely time that we are diagnosing them is after that first-line therapy doesn't work anymore, and we move on to second-line therapy. So some oncologists will do MRIs, some oncologists will wait until their symptoms before they do an MRI. But if there is a positive MRI of the brain, then another agent called tucatinib, which is a tyrosine kinase inhibitor, tends to be a little more used because of the data that it has. It's a smaller molecule. It's supposed to enter the brain much better. Having said that, the data on TDXD is very interesting. It does work with brain metastases. It enters the blood-brain barrier, and it's active there as well. Just
kind of curious, Alexis, there's a Circline regimen that actually has the tucatinib, trastuzumab, and capecitabine. It's often used and particularly effective in brain mets. How do you find patients tolerating that?
I do find some patients tolerate it well, but there are patients who, with that combination, will have like hand-foot syndrome, mucositis, diarrhea. So they do require a lot of symptom management.
I was just kind of flashing. I think we were doing a program on upper GI cancer, Zev, and you had a patient who had HER2-positive brain mets, and I think you were somehow able to get tucatinib, even though it wasn't approved, and this patient had, I think, a gastric cancer. Can you comment on that?
You have a good memory, Neil. This is clear.
Not really.
So yeah, this is a patient of mine who, and HER2-positive GI cancers are really not that common. It's about 15% of gastric, and which we don't see a lot of in this country, and about 2 or 3% of colorectal. But what we do have in common with breast cancer is they do have a tendency to go to the brain, even the HER2-positive GI cancers, which is unusual in GI cancers to have brain metastasis. We don't usually see that, certainly not for the first few years of a typical diagnosis. And so in HER2-positive disease, we do occasionally see it, and we don't have the number of treatment approvals that the breast cancer folks do. I did have a patient who had brain metastasis. We were able to get compassionate use tucatinib for that patient, and it did shrink the tumor for a little while, interestingly.
So let's go on to the next case and the other situation we want to talk about in breast cancer that we alluded to already, which is really a new entity. It seems like it's been around for a while, but I guess was it last year, Virginia, I think? It's
2022 ASCO.
Yeah, it seems like forever. It's like a year ago. Less than a year ago. Incredible. This groundbreaking study that literally got people standing on their feet applauding at the ASCO meeting. But let's get a clinical face on this, Alexis, and hear about your 72-year-old woman. She had HER2 low, but I think you told me she was ER positive?
Yes.
So what kind of therapies had she gotten prior to the time that she got the TDXD? Last night we went through various hormonal therapies, CDK inhibitor, alpelisib. Is that sort of the route she took initially?
Yes.
And then what happened, and she was HER2, what, 1+ or 2+?
1+.
1+, so she was considered HER2 low. So a year ago, she really wouldn't have very many, at least effective options. Again, what were some of the things you went over with her when she was about to start the TDXD? And what happened? Where was the tumor at that point? Was she symptomatic? And what happened when you started the TDXD?
She had went through multiple lines of therapy, and when she started TDXD, she actually did very, very well. Majority of her symptoms went away. She had responsive disease. She didn't really have much nausea or anything of that nature. She did very well.
What have you observed in general? I mean, generally, I think pre-medication is used, like is for chemotherapy. When you do that, what have you seen? Have you seen patients who had significant nausea and vomiting, hair loss, for example?
I have seen patients who've had significant nausea, and majority of the patients do have nausea. What we usually do is pre-medicate. We usually give them home medications like olanzapine, Zofran, and Compazine. And then when they're having their infusion, we also give them pre-medications. We give them some Dex. We also will give them some Aloxi as well as some Amend.
So one of the things about this agent that is very unusual, and Lyudmila, I'm curious, I know you've been very involved with the research on TDXD. We mentioned it initially, is the issue of interstitial lung disease. And of course, even a greater concern in patients with lung cancer who often have other comorbidities, smoking-related problems, cardiovascular, et cetera. Can you explain first what ILD actually is, Lyudmila, how you diagnose it clinically, how patients present?
So ILD stands for interstitial lung disease. Usually patient will present with worsening of the cough if they had a baseline cough or new cough. They can have shortness of breath, which is, again, challenging in lung cancer patients because many of them already have a baseline shortness of breath because of their disease. And then very important for interstitial lung disease to have a very high index of suspicion, meaning as the treating physicians or nurses, you have to know that this is a side effect of this drug. And it's not only important for you to know, but it's also important for patient to know, right? Because you're seeing them with that drug every 3 weeks, right? So if the patient got a dose and they develop shortness of breath 2 days later, you are not seeing them. And if they don't know to call you with those side effects, they might be having an ILD for 3 weeks before you actually see the patient, examine the patient, and diagnose the patient. So I think very important here, A, patient education, and B, physician education, as well as nursing education, infusion center nursing education, to make sure you know what is to ask of your patient who is receiving this medication.
So these patients also get routine pulmonary imaging, even if they don't have the tumor in their lung, hoping to pick it up before it becomes symptomatic. But for any patient, regardless of tumor type, this is a concern. There have been deaths reported. You know, when you cause a death from a therapy, it's a terrible thing you want to avoid. Kelly, can you talk a little bit about how you educate your patients about, you know, symptoms, what you do in the clinic to evaluate their pulmonary status?
Sure. I like to get a really detailed baseline pulmonary history for patients, and I will often get resting, oxygen saturations, and heart rate, as well as exertional with my patients. And while I'm walking them in the clinic, I like to have them talking while they're walking as well for a really accurate test. And then we will talk about the risk of ILD and calling for changes in their cough, chest tightness, wheezing, chest pain, shortness of breath, dizziness, palpitations, fevers because of the risk. There's a rare risk of cardiac dysfunction, and there's also a significant risk of neutropenia. So I go over all of those differentials and ask them to, you know, call me right away if any of those symptoms occur, reassure them that they're not bothering me. In lung cancer, TDXD is approved in the second-line setting or beyond, so these patients are often a bit more symptomatic from their disease. They know the drill with calling for an urgent visit. You're often hearing from their family members. Instead of the patient directly, we always have same-day availability. You know, the evaluation for an urgent add-on patient with respiratory symptoms in the era of COVID is a little bit more cumbersome with our enhanced respiratory precautions and all. But we're typically starting with blood work to make sure they're not neutropenic or not more anemic. I'm starting with resting and ambulatory SATs. If I am concerned because of changes in their vital signs, they'll usually get a PECT since it's the most comprehensive way to evaluate for all of the differentials for that symptom instead of starting with a chest x-ray.
So, Caroline, we were talking this morning about a patient who came in and said, oh, incidentally, a few days ago I had a fever to 103 and you never called to say, you know, it was fine, but never called. How do you enlist the patient? You know, here you want them to tell you, it's very important, we want to know about this. How do you sort of enlist them to bring them into this partnership?
Yeah, it's challenging. In that particular patient, unfortunately, suffers from a mental illness. He's got schizophrenia. So the challenge there is really utilizing, he lives with his mother who is a strong support, so it's really eliciting the support of the family in that setting. You kind of have to, in that situation, I needed to be a little more creative about getting a history from him because he isn't always direct. And I think, there can also be an anxiety component when you say, oh, cough, do you think I have that, that interstitial whatever thing you're worried about? So you have to, there's a lot of observation, just sort of what do you see? Is he short of breath in the room? Is he coughing? Eliciting, a history from the family is also very useful in getting the picture.
So let's get back to this HER2 low situation and TDXD and breast cancer, Virginia. And first of all, we were talking about the fact that we compared two different antibody-drug conjugates in breast cancer. And you can see on the top is TDXD, on the bottom is TDM1, and a very big difference, a huge difference. This is really a revolutionary study, even a survival benefit at this point in time. This is a so-called waterfall plot. I think it's the first time we've showed one of these here. But each one of the sticks there is a patient. And basically, if it goes down, that's the tumor is shrinking down. If it goes up, it's progressing. And you can see, so the more that it goes down, the more responses. It's a much more vivid way than just getting a response rate. And if you just look at the waterfall plot on the left, you can see there's a lot more going down because it's much more effective. And you can see the actual response rate was double. So this immediately led to an approval in the second line setting. And then as Virginia was mentioning, last summer, in June, the paper was presented, and then within a couple of months, the FDA approved it in HER2 low breast cancer. The publication came out, and we saw both in people who were hormone receptor positive and negative, very good response rates. And, I'm hearing, and I don't know, Alexis, in your experience, good responses with HER2 low. It's kind of hard to separate out the quality of responses. Is that, and compared to HER2 positive, have you seen effective responses?
I definitely have seen effective responses. The lady with inflammatory breast cancer, she had a raging, red, painful breast, and now that she's on this treatment, her breast is almost back to normal like her next one.
So I want to explore a little bit more where it fits in now that we're starting to get a feel for how this strategy works. Like then now, how do you figure out where you're going to integrate it into practice? We've talked about in the HER2 positive situation, Virginia. Of course, we've got to keep in mind this ILD. Hopefully we watch the patient carefully enough that they don't have a serious complication. But first, let's talk about ER-positive metastatic breast cancer. What are the usual regimens that are given to a patient? And then at what point do you start thinking about TDXD?
So with ER-positive disease, we start with anti-estrogen therapies, and one of the combinations we use the most is either an aromatase inhibitor or fulvestrant in combination with a CDK4/6 inhibitor, and that's really our standard of care therapy in ER-positive metastatic breast cancer. After the cancer progresses on that therapy, we do have several other anti-estrogen therapies together with other targeted agents that we can give, assuming the cancer is still endocrine responsive. But at some point, some switch happens and the cancer is not dependent on estrogen anymore. And at that point, if you give more anti-estrogen therapy, you're not really going to see much response and you have to move on to chemotherapy. And that's where these antibody-drug conjugates come to play. Now, based on the approvals, we typically give sometimes one line of chemotherapy, even though we try to stay away from chemotherapy. But then we would give either TDXD or another antibody-drug conjugate called Trastuzumab, Deruxtecan, which has been approved in these ER-positive breast cancers.
Right, and also triple-negative breast cancer, another antibody-drug conjugate. This is against a different target, TROP2. What about in triple-negative metastatic disease? These patients often will get neoadjuvant chemotherapy, often with a checkpoint inhibitor. Once they develop metastatic disease, if they're HER2 low, when do you start thinking about TDXD?
So if they have metastatic disease, the first thing we look at is if they have a PD-L1 expression. So if their tumor is, again, sensitive to immunotherapy. And if it is, we may give immunotherapy in that first-line setting. If it's not, then we typically, again, will give a line or so of chemotherapy. But in that second to third-line setting, that's when T-DXd comes to play, assuming the cancer is HER2 low as well. So as you mentioned, now it's a new category, something new we have to look for, not just the fact that this is triple negative, but triple negative HER2 low or triple negative HER2 zero.
As you think about these three situations, HER2 positive, HER2 low, hormone positive, or negative, where does the issue of brain mets fit in? In other words, if the patient has metastatic disease, but also in addition has brain mets, does that affect the way you think about sequence? And we were talking about T-DXd's effect in the brain. What do we know about its effect in the brain in HER2 low?
We don't know a lot of things yet. The data is not out, but it doesn't seem like it would work any differently from HER2 positive disease. You know, when we've all thought of this blood-brain barrier as extremely important in the brain, but once the cancer metastasizes to the brain, the blood-brain barrier is not intact anymore. And if it's not intact, then bigger molecules like antibody-drug conjugates can enter and be effective, and they have been shown to be effective.
We know that in lung cancer, with the, for example, EGFR mutations, RET, other mutations, we're going to talk about that tomorrow night, that those patients, if they don't have CNS symptoms and have brain mets, they often will get systemic therapy and not radiation to the brain, which of course we know can cause damage. Is that ever done in breast cancer?
It absolutely is. So there's a lot of limitations to doing localized therapy to the brain. Obviously, surgery is surgery, and it can have its own complications. When you do stereotactic radiosurgery, you're giving a very high dose of radiation to a small spot, and you can cause radiation necrosis, which is as bad as brain metastases. It causes the same symptoms. And if you do whole brain radiation, again, eventually that can lead to dementia. Now, there's ways of doing the whole brain radiation where you avoid the hippocampus, which is where that dementia starts from. But still, in somebody that you expect them to have a survival of several years, which in breast cancer many of these patients do, you are worried about dementia. So that's where systemic therapy comes to play, and you can actually give systemic therapy, watch the brain disease, and assuming you're keeping it under control, continue your systemic therapy.
All right, well, I think hopefully we've established, sort of a baseline in terms of breast cancer. Now let's see how it's affected these other two tumor types. And Zev, maybe we can start out with just an overview of upper GI cancers, sort of how they present, how you look at them, and then particularly we'll start talking about management of metastatic disease.
So gastric cancer is the most common cancer, one of the most common cancers in the world. We just don't see it that much in the United States. In Asia, for example, Southeast Asia, it's by far the most common cancer, and everybody over there gets screened with endoscopies to identify early gastric cancer. In the United States, it's not as common. What we do see in the United States is more distal esophagus and GE junction cancers, and that's the entity that's much more common here, and that usually manifests as difficulty swallowing, painful swallowing, weight loss, some of those typical symptoms. And patients, unfortunately, in this country are usually found in very advanced stages. It's very rare to find someone with stage 1 or even stage 2 gastroesophageal cancer.
And can you talk a little bit about what you see in terms of HER2 in gastric cancer? Is it evaluated the same way as breast cancer? Any sort of fundamental difference in sort of how you would call somebody at least HER2 positive at this point?
So it's about 15% if you look across the studies of people with gastroesophageal have HER2. There are some subtle differences in the HER2 staining patterns and in the what's called tumor heterogeneity. You might hear that term. But by and large, it's the same process. It's immunohistochemistry, which is protein expression, which is, as you just heard earlier, it reflexes to in situ hybridization if it doesn't reach a threshold. So if it's 3+ HER2 protein expression, it's considered positive in the GI space. If it's 2+, it reflexes to the FISH or in situ hybridization.
Now, one thing that's very different than breast cancer is the checkpoint inhibitors had a major influence in terms of therapy of upper GI cancers. And in fact, even in the HER2 positive setting, you see a high fraction of people who are PD-1 positive. Can you talk about right now, well, first, what was the first-line therapy for HER2 positive disease up until the last couple of years, and currently what it is?
So for the last decade or so, we knew that Trastuzumab should be added to chemotherapy. So the standard of care for the last decade was chemotherapy, and by and large, the chemo we use in gastroesophageal cancers, 5-FU, cisplatin, or more commonly, FOLFOX. FOLFOX is probably our most standard regimen. And we added Trastuzumab to that. And then there was a big study called Keynote 811 that added pembrolizumab to that, added the PD-L1 inhibitor. And as you just pointed out, about 90+% of patients with HER2 positive gastroesophageal cancer are PD-L1 positive. So for now, that is the standard. It's chemotherapy, FOLFOX plus Trastuzumab plus pembrolizumab.
So these patients, once they get to the second line, generally have already had a checkpoint inhibitor and have progressed on it, as well as on Trastuzumab. Can you talk a little bit about, in general, what second-line therapy is for most patients with upper GI cancers, and how you think it through in the HER2 positive situation?
So number one, our second line's a little different than breast cancer. Unfortunately, the patients often progress after about 9 to 12 months, and we don't have multiple lines that much. We have a few lines. And so we have to be judicious about when and how to use these drugs. In the case of gastroesophageal cancer as HER2 positive, if they progress on FOLFOX, Trastuzumab, pembrolizumab, we do now have TDXD, which was recently approved on the basis of actually an Asian study, which, as I mentioned, which most of our gastroesophageal research, a good chunk of it at least, comes from Asia, and we extrapolate some of that data to our patients.
What about the HER2 negative patients? What's their usual second-line therapy?
For HER2 negative, for right now, the standard of care is Taxol ramucirumab.
Of course, ramucirumab being an anti-angiogenic agent. In the second-line setting in HER2 positive, how do you decide between TDXD, which has the ILD as a possibility, and paclitaxel ramucirumab, which doesn't have ILD but maybe not as effective indirectly anyhow?
So we have a thing in gastroesophageal cancer called HER2 loss, and that's actually distinct from breast cancer too, to some extent, where for whatever reason that is not well understood, there's probably about a 25 to 30% group of patients that is HER2 positive at first line but loses HER2. And that's a unique situation. So a lot of times when we come to the decision in second line, we're rebiopsying that tumor, or we're doing these new fancy circulating tumor DNA assays to try to figure out if that patient is still HER2 positive. If they are, which is 3/4 of the time, we are a lot of times offering TDXD now in place of chemotherapy.
You know, it's interesting in oncology, the tumor subspecialties, really, I mean, you've probably never been on a panel together here. You know, they usually deal with things separately, and it's kind of interesting when you contrast what people do. In breast cancer, what I see is once people are HER2 positive, they're HER2 positive. You don't rebiopsy. Any thoughts about that when you hear this strategy? Does that make sense to you? Do you think we should be doing that in breast cancer?
Well, what we've seen in breast is that the HER2 expression, especially in ER-positive disease, actually gets higher over time, and that's one of the mechanisms of estrogen resistance, that you're building up that HER2 pathway.
Really?
Now, what's interesting, what we found with TDXD is that people actually lose their HER2 once they're on TDXD, and we don't really know, because HER2, it's a protein, it gets regenerated all the time, and so the thought is that once you expose the cells to TDXD, they may lose temporarily the HER2 expression, but then it can actually be rebuilt later on.
So let's talk about cases. This is one of your patients, Caroline from MGH, a 77-year-old man who was had a HER2 positive tumor. He actually had brain metastasis. That's really interesting. Were brain metastasis radiated?
Yes, and operated on. So he didn't present with brain metastases. They evolved over time. He presented, in the workup for a prostate cancer, had abdominal pain. They got a CT. He had liver metastases and some diffuse lung nodules. And he started out getting FOLFOX trastuzumab because so he had the liver metastases. They were biopsied. It was a CK set. It had characteristics consistent with a GI primary. He had an endoscopy where they found an esophageal cancer. It was HER2 positive 3+. And so he started FOLFOX trastuzumab, and he got that for quite a while. He also subsequently had a discovery of a bladder cancer, which was becoming active. So his chemotherapy was actually, he needed a little radiation to a bladder lesion and got a little Taxol. But we continued the trastuzumab throughout, which he got for over a year, and then he presented with a seizure and was found to have brain metastases. Had a surgery, had a little radiation, needed a little more surgery and some more radiation. And after that time was found to have progression of his liver metastases. Not new liver metastases, so we didn't actually rebiopsy him. Just growth in the metastases that he had, and then was transitioned to TDXD.
And what happened once he went on TDXD?
So he we started him at the lower dose because he'd been heavily treated over that year. And he tolerated it generally well, lots of fatigue, had some count issues. We were watching his neutropenia carefully, nausea for sure. But over time, his subsequent serial CT scans actually showed quite a nice response in the liver, and his tumor markers over the 8 months he was on the therapy actually normalized. Clinically, he is, a retired mechanic, has 3 grown children, has a few grandchildren, his goals were about wanting to spend more time with them. The fatigue was becoming limiting to him. So he actually, despite his excellent radiographic response, did take a break from treatment and is currently on a break from the TDXD.
That's awesome. What's it been like to take care of him? I mean, it's interesting. I mean, you're using a new therapy. I don't know how many times you'd use it at that point, and it seems to be working. What's it been like to take care of him?
Well, it's that you're always finding that balance of, this is an active treatment, you're responding radiographically, but how, you're always trying to dial in the discussion about your quality of life. And in those moments, it's about hearing from him, what are your goals? This is a second, third line therapy for you, and, how do you want to spend this time? And so those are the discussions with each visit. Now, he was very motivated to be treated because it was in his vision that if I continue to get this treatment and my scans continue to look good, I'm going to live longer and I can be with my grandchildren. But I think at some point he also said, but I don't really have the energy to be with them. So again, a great radiographic response. I think he made a quality of life decision to take a holiday. And our strategy would be to follow him closely. And if there's evidence that things are becoming more active, he didn't progress on the therapy, and we may consider going back to that. And then the other consideration would be chemotherapy.
Kelly, any comment on this issue? It goes way beyond, HER2 disease into the entire area, really, of palliative care, or, taking care of people that you can't cure. This issue of goals. It was interesting that Caroline brought that term out. Do you try to figure out what is important to the patient within the context of maybe they are not going to be around in 6 months or a year? And what are some of the things that you've heard over the years about goals that patients have?
Yeah, absolutely. I'm really lucky to have spent the early part of my career as an NP working with Dr. Temmel, who kind of pioneered the early palliative care for patients who are diagnosed with an advanced disease. So meeting palliative care, not when they're having significant symptom burden or symptom distress, but really meeting the palliative care team are introducing some of the concepts of palliative care within really 4 to 8 weeks of diagnosis. And it can be kind of anxiety-provoking for patients or families to have discussions about end-of-life care when they're trying to be hopeful at the beginning of their journey. But I like to say it's best to have these conversations now when you're able to make decisions for yourself. And so it helps me to make decisions about your care, right? Like Caroline said, making recommendations for a chemo holiday, or understanding that a patient is prioritizing quantity over quality because they want to make sure they get to their son's wedding in May. Versus some of our patients who are actively watching grandchildren and want to have the energy to take care of them. So I think we try and have that conversation before they start therapy and then at pivotal points during their treatment. So around restaging, the time of restaging, or at progression, to really make an informed decision about what they want. I always say to the patient, I'll be honest with you. I'll make a recommendation based on my experience and the relationship we've built together, but you're the boss here. And set the expectation that treatment breaks are possible, and that when we can't cure the disease, quality of life is as important to me as actively treating their cancer. And that unfortunately there are no guarantees that if we take a treatment holiday for toxicity, and you were responding to that therapy, that when we resume that therapy, you will respond to it again. So there's never guarantees, but I try and establish that kind of trusting relationship, saying that I will let you know when I am worried.
So Alexis, I think it's so important to talk about this because we get all excited. We do standing ovations because the data looks so great. But then it comes back to what does it really mean to the patients? Anything you want to mention in terms of what we've been talking about goals of patients? Also, I'm curious whether you see difference culturally. San Antonio, as you mentioned, has a lot of Hispanic people. We're located in Miami, same situation. Anything that you observe different culturally in how people approach talking about it and kind of what goals they set in a palliative situation?
So you are correct. It is very. We do have a lot of Hispanic patients here, and they don't do advanced care planning. They don't talk about death and dying when it comes to that. Usually the family makes the decision at that point, but they're not open about it. They don't want to talk about it. Sometimes if you bring up advanced care planning, because that's kind of what we're taught to do, let's talk about it early. What are your goals of care? Let's do medical power of attorney and DNRs and DNIs. We talk about that in advance, and sometimes our Hispanic population get offended.
Interesting. So Caroline, here's another case, and unfortunately this is a patient who did develop pneumonitis, a young patient, 42 years old. What happened to him, particularly what happened to him when he was on the TDXD?
Yeah, so this is my patient who, he's a great guy. He suffers from schizophrenia, and when he had a surgery and then had a recurrence and metastatic small volume metastatic disease, just a paratracheal lymph node, got treated with chemotherapy and Folfox and Trastuzumab. Unfortunately, he was very challenging to stay on task, and he had a lot of delays and ultimately didn't like the oxaliplatin, so kind of skipped a lot of chemo and ultimately had progression. But his progression was locally, so he had a lot of dysphagia, a lot of discomfort, frustrated he couldn't eat and drink the way he wanted to, was resistant to get a tube. So went on to second line Trastuzumab Deruxtecan, and he tolerated it fairly well. His motivation to continue on that treatment was that his dysphagia improved significantly. And even though he had very low volume metastatic disease, and when we would serially scan him, the difference in, millimeter change in that paratracheal lymph node, not that impressive, but his quality of life was so much better. He was getting serially dilated, having an endoscopy every, 6 weeks, and suddenly he didn't need them anymore. So he'd had a nice response locally. Unfortunately, he then called one day to say, I'd like to get a new tattoo, is that okay? And oh, by the way, I have a cough. And I'm talking to him on the phone. He's like, So he comes into clinic. He's got a fever. We get a CAT scan, and he has ground glass opacities bilaterally, consistent with a drug effect. So he had to come off the drug, and is currently, this was actually quite recent, and then he got COVID, so he's navigating all of that. But he's on high-dose steroids in his taper and tolerating the taper well, but likely he won't go back to TDXD.
Yeah, interesting case. Does that have any comment about this history of just minimal shrinkage having such a big effect on swallowing? Is that something you see commonly?
So, first of all, this is a very challenging patient because, we all know taking care of patients with mental illness and cancer is a big challenge. And we've all had many patients, I would say, because we know that people with mental illness are a little more likely sometimes to present with late presentations of their cancers. So we're becoming familiar in oncology to how to navigate these things. And I think, the way Caroline's team managed it, making sure that there's a good advocate for that patient is the most critical thing, because the patients sometimes can't advocate for themselves in these circumstances. With respect to the clinical symptoms, you do see sometimes differences in how a tumor responds on a CAT scan, let's say with a liver lesion, and how they respond in this tumor itself. And in gastric cancer, which is, as I mentioned earlier, there is differences in HER2. Amazingly enough, if you take the same patient and you biopsy their stomach, and at the same time you biopsy their liver, you'll see different levels of HER2 expression. And so it may be that the HER2 dependency of this patient was more so in their primary tumor than in their metastatic disease.
Oh, that's interesting. We got a number of questions about dose of TDXD. Zev, can you comment on sort of how the dose evolved in upper GI cancers, and do you, if you have tolerability issues, chemo side effects, or do you reduce the dose?
Yeah, so we started at, remember, I think we talked about this, it came from Asia, so we started a little bit of a higher dose and then came down subsequently. Dosing is a big thing with the FDA. There's a big emphasis now on, do we really need that dose in oncology? And a lot of the studies are being done to look at different dose levels. So we tend to, in oncology, try to push the doses. As we all know, that's the emphasis is in clinical trials, to get to that top dose or maximum tolerated dose till the side effects occur. But we're seeing changes, and this is a good example because we probably don't need that 6.4 dose for the benefit of the majority of patients.
So I just want to ask you before we go into lung cancer, I saw this paper in the Journal of Clinical Oncology. I was kind of like, whoa, that's interesting. HER2 low gastric cancer response to TDXD. Any comment?
Well, number one, this is, as you saw here, Japanese study, so they have the benefit of having all these patients and doing all these studies. The responses weren't great, I will say. These are very small numbers, and certainly nothing like what Virginia just talked about in breast cancer. It's nowhere approaching that level. So we're not yet at the point where we can say, gosh, this is a drug that ought to work in someone with HER2 low gastric cancer or colorectal cancer. There was a parallel study with HER2 low colon that showed no benefit of TDXD in HER2 low. So we're not quite there yet.
I don't know. It looks like the things are going down there to me, but maybe not enough. Few things, huh? Okay. And then, let's move on, though. You mentioned colon cancer, though. Maybe you can just talk briefly about HER2-positive colorectal cancer and the role, if any, of TDXD.
So there, it's really small. It's maybe 3% of metastatic colon cancer. You have to really look for it, because if you're not looking for HER2 in colon cancer, you'll never find it. It's not part of the traditional panel of colon cancer the way KRAS and BRAF and MSI is. It's a new marker. And so we are starting to look more, and we're starting to find a few more. But 3% of colon cancer is a common cancer, so you end up seeing enough patients. We don't yet have an approval of TDXD. It's on the NCCN guidelines. We do have an approval, interestingly, just recently, of tucatinib and trastuzumab in HER2-positive colon cancer. So the kinase inhibitor and trastuzumab just received FDA approval in the last 6 months, actually, for HER2-positive colon cancer. So we have something there.
You know, interesting about that tucatinib trastuzumab combination. What do you tend to use first?
So when this situation arises, right now we're using tucatinib trastuzumab first because that's FDA approved. And,
Right.
and in that study, the majority of the patients were untreated HER2, whereas in some of the TDXD patients, they had already received some HER2 therapy. We'll see what the FDA does with that data set, and there's going to be an update on that at ASCO.
Interesting. Okay, so let's talk about lung cancer. Kelly has a 67-year-old man. But before we get to that, maybe just we could just talk a little bit about what we know about HER2 positive, really HER2 mutant in particular. You talked a little bit about it, Lyudmila. Right now, what are we thinking in terms of where TDXD you think is going to be fitting in? You know, in lung cancer, we have a lot of different targeted therapy. I'm not sure whether you call this targeted or not. It's sort of targeted. It's sort of chemo. But in general, what we see in lung cancer is if you have a targeted treatment that has a 50 or 60% response rate, a lot of times people use that initially. Where are you thinking right now TDXD is going to fit in, particularly Lyudmila, in a HER2 mutant situation?
So currently, the FDA approval of TDXD for HER2 mutant lung cancer is in second line, because that's where the DESTINY-Lung01 and DESTINY-Lung02 trial were done. There are ongoing trials in first line called DESTINY-Lung04, which will compare trastuzumab deruxtecan or TDXD versus standard of care carboplatin, pemetrexed, pembrolizumab. And there we will know if there is enough efficacy in TDXD to move it into first line. The efficacy in second line is actually respectable, 55% response rate, PFS of about 6 months, duration of response of about 10 months. This is kind of in the same ballpark that I would expect with a platinum doublet. You can argue about the utility of immunotherapy in non-smoking mutant lung cancer, but I think for that we need another 30 minutes on my plate so I can talk about controversy. I think before we go any further, what I want to highlight is the difficulties that we as a lung cancer physicians, as well as our lung cancer patients, are having. So when we talked about HER2 positive in breast as well as GI cancer, it's an immunohistochemical stain that requires one slice. Turnaround time is 48 hours. Any minimally respecting itself institution will have that test available to them. Mutation requires tissue, usually send out tests. Usually we do next generation sequencing. Turnaround time is 3 weeks and needs more tissue. So in lung cancer, we commonly have an issue of insufficient quantity. And in addition, not just having insufficient quantity, but our penetration of next generation sequencing in lung cancer is no more than 70%. So if you didn't do next generation sequencing, you do not know that your patient have a lung mutation in HER2. And I think as a lung cancer physicians, we definitely need to learn from our breast cancer physician, because nobody even gonna attempt to manage patients with breast cancer without knowing HER2 status and estrogen receptor status. As a lung physician, nurses who take care of lung cancer patients, we should not attempt to think about what you give to a lung cancer patient until we have next generation sequencing results. And that's very important.
Assuming you can get it paid for, which is always, not always, but sometimes an issue.
It is an FDA approved right now. So next generation sequencing FDA approved for lung cancer.
Interesting. So what about the patient, and we'll get to Kelly's case in a second, but Lyudmila, we talked about the concern about interstitial lung disease. What about the patient who's already short of breath? They've got tumor in their lung, or they've got chronic lung disease or cardiovascular disease. How do you deal with TDXD if they already have pulmonary symptoms?
I think one is it's important to understand why are they having those symptoms. Are they having those symptoms because of the disease burden? And then maybe for that, the treatment would be to give an effective therapy that will decrease the disease burden. or are they having that symptoms because they have comorbidities? Majority of the patients with HER2 mutations are never smokers or former light smokers, so we don't see as much of an incidence of emphysema or COPD in those patients, but you can certainly have a patient with pre-existing unrelated pulmonary fibrosis or some other things, a patient who, for example, had a lung removed and now is with one lung. So it's challenging, and I think that's where you have to make sure that there is nothing else that is as effective, because the efficacy of docetaxel or docetaxel plus Rami in this situation would be 8% response rate, PFS of about 4 months. 50% response rate, PFS of 8 months, so it's a big difference. I rely very, very heavily on my nurse practitioner and my nurses to make sure that somebody is keeping an eye on the patient more frequently than I can.
Interesting. All right, let's hear about your 67-year-old man, Kelly. What happened with him?
So he is a 67-year-old man, never smoker, and he, we rely a lot on family members to tell us if patients are having symptoms after their treatment so that we can effectively manage their symptoms or make modifications to their treatment. We also rely on family members to help get us care when we are minimizing symptoms. So he is a gentleman who had a dry cough for about 6 months and only presented to his PCP for evaluation because his wife couldn't take the coughing interrupting television at bedtime. So she dragged him to the PCP, and he had a chest x-ray which showed a 1.8 centimeter left apical nodule. The PCP ordered a PET CT which showed this left apical nodule concerning for lung cancer, as well as 2 small right lower lobe nodules. It was unclear at that time if this was truly a metastatic process. He only had this minimal chest disease, or if it was possibly 2 primaries. He went on to have a biopsy of the left apical mass, which was a lung adenocarcinoma with the HER2 L755P mutation. And he went on to have a wedge resection of the right lower lobe masses. And then he went on to receive carbo-pembro, which is the standard first-line therapy for metastatic disease. It was given more, though, to see if he could sort of declare himself. Would he respond to the carbo-pembro, or would he have progression of disease and really kind of declare himself as a patient with metastatic disease? He tolerated carbo-pembro horribly. He was a healthy gentleman with really no comorbidities, but he had significant fatigue and appetite changes, nausea, problems with his counts. So after 2 cycles, he was restaged and had a really nice response, and he actually went to surgery to have the left apical mass removed and to complete the right lower lobe lobectomy. And he then got 8 months off of therapy, seeing him every 3 months or so for surveillance scans. And unfortunately, around 8 or 9 months, he recurred with metastatic disease in the lungs and the bones. And at that time, he had tolerated the carbo-pembro really poorly. We knew about the HER2 mutation. Trastuzumab Deruxtecan was not yet approved in lung cancer, but we extrapolated from the GI data and started with the higher dose of 6.4, actually, because he hadn't been really heavily pretreated. He had, like I said, tolerated first-line therapy, horrible, and shockingly, he breezed through TDXD. He had a little bit of fatigue and brain fog, he would call it, for about 4 days, some mild nausea, no vomiting. He continued, he sold his business, but he continued to be heavily involved in the business. He hikes, he travels, he does great. And then when the Destiny Lung 2 data came out supporting a lower dose as a starting dose for lung cancer patients, we reduced the dose from 6.4 to 5.4, just to be consistent with the labeling. As Zev said, the FDA really likes the dosing and the labeling, and he's continued to tolerate it well with a great response.
How long has he been on the TDXD at this point?
He started in July.
What's it been like to take care of him? Earlier you mentioned, I was going to ask you more about it, about sometimes that people feel stigmatized by lung cancer. You mentioned he was a non-smoker. What's it been like taking care of him, and what's it like taking care of smokers?
I would say it's very different. Unfortunately, a lot of there's sort of 2 camps of patients who are smokers. There are the smokers who have 80 pack years and still can't believe they got lung cancer, never really internalized that was a possibility for them, and they're so angry. And then there are the smokers who say, I did this to myself. And you have to say, like, no, you didn't do this to yourself. You didn't know when you started, or if you did, like, that's okay. You didn't ask for this, and I'm here to help you regardless. So I think it's really hard to overcome that. Often we see patients who are never smokers, and when they pass away of their lung cancer, their family specifically puts in their obituary non-smoking related lung cancer.
Interesting. Lyudmila, can you talk a little bit about what we've learned about TDXD and HER2-positive lung cancer? We're already hearing lots of differences in the GI and the breast and lung. Now you're talking about HER2 mutations. Also, the issue of dosing, again, in lung cancer, what was seen in the trials and where you see things heading. You mentioned now it's being looked in the first-line setting.
So I think dosing story is very interesting. So when the TDXD was first developed in lung cancer, we used 6.4 mg per kg dose, which is a GI dose. The breast dose is 5.4. And great responses, durable responses, but the issue was that we saw 26% chance of interstitial lung disease. Compared to the GI and the breast numbers there, I'm not that that's not my expertise, but it is about single digits, like 2-3%. And in lung cancer, suddenly we see 26%. Why? We don't understand. Same drug, same target, different patient populations. When we looked at the Lung-01 trial, trying to figure out, can we determine up front which of the patients will have interstitial lung disease, nothing panned out. Gender is not predictive. Site of the metastasis is not predictive. ECOG status is not predictive. So we don't know which of those patients develop interstitial lung disease. You mentioned before that fatalities have been seen from ILD in Destiny Lung-01. So then we ran a Destiny Lung-02, and a Destiny Lung-02 was a randomized head-to-head phase 2 comparing 6.4 and 5.4 mg per kg dose. And then we saw that response rates were very similar. The progression-free survival was very similar. The incidence of interstitial lung disease in 6.4 dose was 14%, not 24, 14. I have an explanation for that if you want to know later. And then the 5.4, the incidence of interstitial lung disease was about 6%. So that was the main rationale for FDA approving 5.4 because efficacy was not different and ILD was much lower.
So we're going to hear about the final case in a second, but Lyudmila, can you comment on other ADCs, including other ADCs that target HER2 in lung cancer?
So right now, there are a couple of ADCs targeting HER2, but they're very early in development. I think what we are excited in lung cancer is a HER3 ADC, which is a Patritumab Deruxtecan, which looks very promising in patients with EGFR mutation. And Virginia was talking in the beginning that it's a family of receptors. EGFR is a HER2-1, and this is a HER3. And in the patients who have a EGFR mutation, who have resistance to traditional EGFR TKI, the Patritumab Deruxtecan response rate is a high 30s, like 35%, which is very reasonable. Also in lung cancer, TROP2 ADC look very promising. There is an AXL ADC, ROR1 ADC, so I think ADC is here to stay in lung cancer for sure.
Any unusual toxicities? We were talking yesterday about an ADC in cervical cancer, one of several that cause ophthalmic issues. Have that been seen with any of the lung ones?
We were watching for keratitis very carefully for TDXD, and the incidence of keratitis is very low, but we see keratitis in TROP2 ADCs in lung cancer.
Interesting. All right, so let's do one more case here. Kelly, you're a 69-year-old man. What happened with him?
This case actually reminds me of Caroline's case. So a 69-year-old gentleman, again, a never smoker. He, in 2016, had a sacrococcygeal chordoma, which was resected, and he received radiation. During his surveillance period after that local therapy, about 2 years later, he was found to have a new lung nodule. It was thought to be an metastatic disease, a recurrence of his chordoma, and he was taken to the OR. And the frozen path actually showed that was a lung adeno with HER2 on final pathology. So he went on to have I believe it was a left-sided, left lower lobectomy, completion lobectomy, and mediastinal staging. And he was found to have a stage 3B lung cancer. At that point, it had been resected, so he went on to get adjuvant concurrent chemotherapy and radiation with weekly carboplatin and paclitaxel. And about a year after he completed that curative therapy, he had a recurrence with some bony metastases and a new pleural effusion. He went on to get first-line therapy with carbo-pem-pemro. He received 4 cycles and then went on to maintenance therapy. During his first-line therapy, he was found to have an enlarging pancreatic mass. He was taken to the OR for that, and that was a pancreatic neuroendocrine cancer. And he continues to follow with our GI colleagues, but he remains on active therapy for his lung cancer, since that's the one that is sort of riskiest, obviously, to his survival. So we went on to get carbo-pem-pemro. Unfortunately, he progressed. He had new brain metastases and systemic progression, and ultimately he went on TDXD. Because of his prior treatment history, he started a little bit lower. He started at the 5.4 mg per kg dose, and he tolerated it really poorly. He required a dose reduction for cycle 3 because of neutropenia, constitutional complaints, lots of nausea, vomiting. He did fair for 4 more cycles. His restaging scans after cycle 6 had showed a stable disease, and he was just burnt out, and he took another chemo holiday. During that chemo holiday, he was coming in monthly just for kind of symptom checks, and every 2 months getting restaging scans. Unfortunately, he developed brain metastases during that time, and he required whole brain radiation. He had a significant burden of CNS disease. He remained kind of progression-free systemically. We were able to continue the systemic holiday to allow him to recover from the whole brain radiation. A few months later, he had systemic progression, and we had to restart the TDXD, which we started at, again, a lower dose even. He was getting 3.4 mg per kg, and now he's tolerating that reasonably well.
Wow.
He's had an improvement in his functional status. He's been traveling. He took his grandkids to Disney.
Wow. Never would have expected that. He was HER2 overexpressed or mutant?
Mutant.
It's just like what we've been talking about. What's it been like to take care of him? I'm hearing this whole story. I'm saying it sounds like what a terrible situation. Now you say he's going to Disney World. What's it been like to take care of him?
So I didn't meet him at the beginning of his diagnosis and treatment journey. I met him when a colleague was out on maternity leave. I think that was challenging because I didn't meet him from the beginning, and so he was like testing me out. And things hadn't gone easy for him, right? This is like his 3rd cancer in 3 or 4 years. Every time he was taken for a resection for some like local recurrence or what they thought was curative disease, he had a new diagnosis and was embarking on a new really toxic therapy. He had had a lot of side effects. So, it was a bit challenging to kind of tease out the symptoms. It's the same, it's the same, it's the same. And I didn't know you back then. Like, please tell me exactly what you mean by that. We were always restarting the conversation. But he really appreciated, I think, the time off of treatment to try and improve his functional status and make some more memories with his family. It was hard to teach him. It was hard to manage his expectations, to set expectations for him, because he had always gotten bad news. And so it's nice now. Now he's in a time of stability, and he's feeling well, and I think he's getting a little used to that. He's got a couple of good months behind him, and he is more hopeful for the future.
We talked about what you all mean to these patients, and you hear it when you hear these cases described. We change their goals, and you meet their new goals. So just to finish out, Virginia, we've talked a little bit about where things might be heading in lung cancer and upper GI and colorectal cancer in terms of HER2-positive disease. A lot of it seems to be following, the lead that you all created. What are you seeing in the future? And of course, we always think earlier in oncology in general. So, for example, do you see this moving up into the post-neoadjuvant or even neoadjuvant space in HER2-positive disease?
Yeah, so there are trials, and they're large randomized global trials now looking at TDXD in the adjuvant setting, and I think that's exactly what we need to be doing. In the metastatic setting, we're combining it with tucatinib, for example, to see if there are other combinations that might really help us avoid true chemotherapy completely. And then there's this new again category, the ultra-low. So those are tumors that are HER2 zero, but not completely zero. And so that's where pathologists become so important, because now they have to identify these tumors that have a tiny little bit of expression, not enough to call it 1+, and we're going to be looking at TDXD in that setting as well.
Yeah, oncologists are always asking the pathologist, come on, you can find some HER2 in there. And actually, HER2 zero has a little bit of, I think it's up to 10%, so there is some there. Maybe it will turn out. Really, I don't know that there's another situation in solid tumor oncology that's what's done in HER2 positive disease, which is neoadjuvant therapy. And then, okay, if they have a path, they go to surgery, there's no tumor, fine, you keep the therapy going. But if there's tumor there, then you switch to something else. And up to now, it's been TDM1. But we already know in the second-line setting, TDXD was way better. So I would imagine people are going to be very enthusiastic about bringing TDXD into that post-neoadjuvant space, and also maybe even adding in tucatinib in that situation to help with brain mets. Are there trials with that kind of strategy?
There are trials, and that's where toxicity becomes even more important. We know in the metastatic setting, obviously, the majority of those patients are going to die of breast cancer, and so we know ILD obviously is important. 10 to 15% of patients with breast cancer will develop ILD with TDXD. But now you're talking about the curative setting, and where even if 5% of your patients, that means 5 in 100 will develop ILD, and what is the grade of that ILD? That becomes even more important there.
And then you balance it against risk. Metastatic disease is going to be the greatest threat in general for all of these patients. Well, it's been really a lot of fun. It's been different. It's been an experiment, but I think it worked. It's been really interesting. We've never contrasted different tumor types. I've learned a lot, and it'll be really interesting to see where we are next year at this time. So thanks so much to the faculty. Thank you for attending. Going back tomorrow morning, 6 a.m., hepatocellular cancer.